The following video is an attempt to demonstrate a few of the most valuable classical osteopathic procedures used at the home, hospital, or clinic bedside for more than the past century for the examination and treatment of the patient suffering acute respiratory disease. Particular note should be made of the coordinated and rhythmic use of long lever and relatively stabilizing fulcrum. This is to ensure as broad an anatomical field is taken into consideration as possible. Treatment being the attempt to improve or restore, to the degree possible, smooth and rhythmic coordinated activity in all the related conjoint structures. It will often result in positive clinical responses that may continue for days and longer following treatment. In a home visit, the sick patient is usually confined to a low and soft bed. Special skills are required to ensure an efficient treatment and without endangering or exhausting the operator kneeling by the side of the bed. A separate video will be devoted to the subject. Therefore, wherever and whenever possible, treatment at the home bedside is best accomplished with the patient in the sitting position and is demonstrated in the following sequence. The sitting position enables extensive, rapid and comfortable examination of the whole spine, ribs, and their myofascial attachments. From superficial to deep, a palpatory search is made for pseudomotor and localized thermal abnormality expressed as hot or cold spots. All movement procedures must be conducted rhythmically in order to detect degrees of arrhythmicity and thus location of potential dysfunction. A hallmark of classical osteopathy is that within one sequential flow of movement, these same examination maneuvers can become surgically precise treatment procedures when dysfunction is met. Next is shown the search and treatment within the anterior throat myofascia for any undue tension or resistance to movement that may cause neuro, microvascular or lymphatic compromise. Moving from superficial to deep, the head and neck are used as a lever to simultaneously relax and tighten the structures under the operator's palpating and treating hand. In testing and treating the thoracic spine, the operator's thenar and hypothenar eminences are placed over the articular processes, the spinous processes lying between, while coupled side bending and rotatory vectors are introduced down to the specific segment by both the arm leverage of the patient and the operator's wrists and fingers. If capable, the patient clasps his arms around the operator in order to enable specific intersegmental traction targeted by the operator's wrists, forearms and fingers as fulcra, focusing and stabilizing the segment. Flexion, extension, rotation and side bending coupled movements are introduced to both diagnose and treat points of resistance. If the patient is too debilitated to raise his arms, then the operator inserts his hands and wrists from below the armpits of the patient's lowered arms. The examination and treatment of points of resistance of the anterior costal articulations is demonstrated. The arm is elevated at the precise angle needed to engage the moving rib fulcra fixation of thumb or fingers, above or below the rib shaft, to enable strong mechanotransduction effects on the underlying nociceptors, proprioceptors and mechanoreceptors. Note that palpatory feedback is always from fulcra and lever. Next, the head and neck is being used as a dynamic lever for the diagnosis and treatment of the cervical spine. The operator's forearm and flexed wrist splint the patient's neck for safety to avoid undue side bending while introducing coupled flexion, extension, and rotation. It is a continuous rhythmic interplay between lever and fulcrum, not least determined by tissue reaction when it is time to terminate the maneuver to avoid irritation and damage to highly reactive connective tissue during fever states. In order to introduce and to induce downregulation of the sympathetic nervous system, bilateral thumb pressure is applied slowly and rhythmically from transverse process to the superior and laterally located transverse processes of the same segment, moving the erector spinae superiorly and laterally ahead of the thumbs. The attempt is to approximate as closely as possible to the underlying posterior medial ramus of the underlying sensory nerves, the osteopathic peripheral portal of entry to the dorsal root ganglion, central and autonomic nervous systems. Next seen are splenic and hepatic pump procedures employed to enable leukocyte recruitment, but only if without causing discomfort or pain, and may be contraindicated in the presence of significant splenomegaly, hepatomegaly, or atrophy. It is a mixture of rhythmic bilateral mobilization and simultaneous squeeze pump maneuver, its depth and rhythm determined by the absence of discomfort and organ resistance to the bimanual pressures. The side-lying position may be the only comfortable and effective position in which to treat the home patient, who is usually confined to a low home bed with a soft mattress. It allows for maximum relaxation of the erector spinae and allows for excellent and usually pain-free diagnosis and treatment of points of resistance. The operator uses his body weight on the pelvis or resting on the shoulder to stabilize the patient and focus the leverage forces. Deep rhythmic inhibition is applied to the erector spinae unilaterally, the operator using his thumb and thenar eminence between spinous process and transverse process to draw the erector spinae laterally, its depth, as always, determined by the tissue resistance and the need to gently and painlessly overbear this resistance. With regard to the cervical spine, the operator first comfortably stabilizes the patient's body with his own body weight, gently cradles the patient's temporal region with his forearm and wrist, and uses the head and neck as a lever. Examination and treatment is carried on down into the upper thoracic region. The operator's thumb placed lateral to the spinous process or deep to the articular process. The anterior and lateral rib and costocartilage articulations are examined and treated easily in this position. Where the patient's comfort permits the supine position, it affords excellent access to all the anterior thoracic and cervical structures and thoracic inlet. Note how it is the dance-like use of the operator's body that conveys the primary movement pattern and rhythm. Where it is difficult to induce smooth, rhythmic articulation of articular or even abdominal organ structures, it enables the operator to detect and diagnose dysfunction. Particular attention is paid to ensuring that there is no restriction or compromise of neurovascular bundles or lymphatic vessels in and around the thoracic inlet. Where necessary, enhanced raising and freeing of the clavicle from its underlying attachments is possible, where restriction of movement and potential subclavicular compromise of underlying neurovascular and lymphatic structures is suspected. The patient's upper arm is levered over the operator's thigh as a fulcrum, while the operator encourages further elevation with his fingers pulling upward from beneath the clavicle. The examination and treatment continues with the rotator cuff and underlying scapular attachments and scapular rhythm. Particular note is taken of the freedom or otherwise of the first and second ribs articulations and undue scalene muscle tonus. A most valuable, minimally invasive, unilateral thoracic lymphatic pump procedure is shown. The patient asked to breathe in rhythm with the maneuver. The pressure must be carefully graded and painless to avoid damage to underlying potentially congested pulmonary parenchyma and fragile inflamed alveoli. It may be contraindicated in infection with severe secretory congestion or consolidation. On the other hand, the modulating negative thoracic pressures induced by the maneuver may play a significant role in augmenting lymphatic flow and drainage of lung secretions. The following maneuver can be detected carefully in the most fragile of patients and was colloquially known as the osteopathic lifesaver or osteopathic mustard plaster. It simultaneously enables a mild thoracic suction pump effect, a release of the superficial and deep thoracic soft tissues of the thorax on their underlying bony attachments, and the gradual bilateral mobilization of every part of the thoracic cage. Requiring a high level of manual and body dexterity, the operator engages and grasps the underlying rib angles with one hand, while the upper hand is accurately placed over the same ribs over the anterior chest. Engaging the liver bimanually, the lower hand grasps and pulls superiorly beneath the costovertebral angles, while the organ is squeezed beneath and between the upper and lower hands. Similarly, on the patient's left side, treatment is often carried caudally to include the splenic pump. Where the bilateral thoracic pump may be judged too vigorous in the face of advanced pulmonary pathology, the abdominal pump is often a valuable alternative to enhancing lymphatic circulation and leukocyte recruitment simultaneously. The hand force vectors are directed caudally, inferiorly, and slightly laterally in the direction of the liver and spleen. In the treatment of the neck, the placement of the operator's hypothenar eminence beneath the patient's mastoid is essential in order to magnify the coupled vectors directed to the fingers around the spinal segment. Under light traction, Fryet's principles of spinal movement are employed as everywhere else in the spine to ensure the minimum of strain to entheses and articular capsules. This was a cervical maneuver used par excellence by Little John, who refused to teach or use high-velocity manipulative techniques, which he considered potentially dangerous, unphysiological, and unnecessary. In regard to the upper thoracic spine, the operator's thenar eminence is accurately placed beneath the patient's mastoid bones, the fingers engaging the thoracic spinous processes while inducing side bending and rotation to each segment via the leverage of the head and neck. The degree of flexion or extension of the neck is applied as required to enable the maximum facet disengagement. In the examination and treatment of the anterior throat structures, particular attention is paid to ensuring the freedom of motion of the hyoid, to which all superior and inferior strap muscles and fascia attach. Note once again the use of push and pull interplay of lever against fulcrum. Examination and release of any platysmal tension is conducted to ensure free lymphatic flow and reduce painful throat inflammation. Examination and treatment of the myofascia of the face in the case of opportunist infection of the sinuses, eyes, or middle ear. A search is made for points of resistance in all the fascia, myofascial attachments that may impair lymphatic and venous drainage into the thoracic inlet from the eyes, ears, and sinuses. Release of these points of resistance is attempted, followed by maneuvers designed to stimulate lymphatic flow, following the anatomical pathways and directions of such flow into cervical lymph glands via the angle of the jaw. In the presence of fever, the deep suboccipital attachments are drawn superiorly and laterally along the nuchal line. Its aim is to downregulate embedded primary afferent nociceptors, and thus modulate neural signaling to the medullary thermoregulatory center, often reducing the temperature by 0.5 to 1 degree Celsius in fevers. This can be especially valuable in the vulnerable young child. Where the prone position is possible, dermal hot or cold spots, pseudomotor changes, or stickiness is looked for. A rhythmic, oscillatory wave is passed rostrally from the pelvis to the upper thoracic spine, met by the microfulcra of the operator's fingers, lightly stabilizing the segments beneath. Particular attention is paid in lung disease to areas segmentally related to the pulmonary field. Arm leverage is next employed. Note that the lever hand is equally involved in examination of conjoint actions as is the operator's other hand. The insistence on the precisely directed use of long leverages as the most safe, effective, and physiological means of diagnosis and treatment is a hallmark of Still and Littlejohn's techniques. A splenic plump maneuver is possible in the prone position when not contraindicated clinically. Its depth and rhythm determined by the organ's resistance and the patient's comfort. Comparing and contrasting with the other side, the maneuvers are followed by a liver pump. Now seen is deep, slow, inhibitory and sedative pressure from spinous process to the transverse process of the same segment. The attempt is made to approximate as closely as possible to the posterior primary medial ramus of the underlying afferent sensory nerve, from T2 to L2, to affect the sympathetic spinal cord gray cells as they converge in the cord with afferent sensory nerve ingress. The erector spinae are moved laterally ahead of the thumbs. The final demonstration is that of inhibition to the celiac plexus, the operator's fingers moving increasingly deep as the abdominal muscles relax each time the patient breathes out. It's performed in a semicircular direction from 12 o'clock to 12:45, and then partially released till 12 o'clock. Major sympathetic, parasympathetic, and nociceptive pathways pass through and converge in the celiac plexus. It is often very tender, and its sedation may play a significant part in restoring a more regulated immune response when excessive. It is hoped that this short explanatory video will provide the osteopathic viewer with a window into the range and depth of procedures developed clinically by the founders of the profession in the face of serious systemic disease and epidemics. It is hoped, too, that they may encourage the viewer to deepen his studies in this field, which has as much clinical relevance today as it did over a century ago, either as a standalone treatment or as an invaluable adjuvant.